Great, that's YouTube is live now also. Good, so we have a couple of hundred people online now already. And so we're expecting another 100 people roughly. So we should be all okay to start, if it's okay with you all. So good evening, everybody, and many thanks for logging in and attending. This is the 21st webinar with our breast book. And it's just over a year since we started. So it's great to see that we're still getting good numbers for those webinars. It's a great webinar today. It's about the little things that matter. So it's not technical webinar. It's not webinar about treatment. It's about things that matter. So it's more patient advocacy webinar, how to find information and what things we can, what little things can make a big difference. And we have a great panelists and speakers. We have Louise Grimsdale from Breast Cancer Now is going to talk about information about patient-focused resources. We have Giuseppe Catanuto from Catania in Italy and from the Italian group Greta is going to talk about shared decision-making. And we have Liz Oridian from England, and Liz is going to talk about the little things that matter. And Liz has published her own book about breast surgeon and breast cancer and has lots of social media presence. So it's great to have all of them here with us today. We have Terri Coutee, and Terri is a patient advocate from Seattle in Washington, and she runs a great online resource for people that want to go for the EAPS, called the DFC Foundation, and Terri will share all the links on the chat function. And we have also Minas Chrisopolou, who's one of the plastic surgeons from San Antonio, from Texas, and has done lots of patient advocacy work. And you need to know about the Breast Advocate. It's a great app that you can find lots of resources there. So we'll start with the talks. We'll start with Louise first, and Louise is going to talk to us about information, patient-focused resources. Louise, the next 15-20 minutes are all yours.
Great, thanks, Suzanne. Just share my screen. Okay, so I'm Louise Grimsdale. As Yazan said, I'm a clinical nurse specialist, and I've been working at Breast Cancer Now for the last just over 2 years. Prior to that, I was a clinical nurse specialist in breast cancer in the NHS for just under 15 years. So the purpose of my talk really is to talk about the importance of patient information and patient-focused resources. So information needs for patients. So having a diagnosis of breast cancer can feel completely overwhelming. The information people need to digest in that first few weeks and months when they're first diagnosed. So their diagnosis, the grade, the stage, the type of breast cancer they have. The treatments, we know that the treatments for breast cancer are becoming so much more complex now. Chemotherapy, neoadjuvant chemotherapy, adjuvant chemotherapy, and possible chemotherapy again after surgery. Surgical techniques are becoming much more complex, and the range of reconstruction techniques are also becoming much more complex. Endocrine therapy as well, again, is a whole host of offers that and options that are discussed, and radiotherapy in addition to that. Along with treatments are the side effects that come along with all of those treatments. Some of those are temporary and short-term, the side effects of chemotherapy like nausea, vomiting, hair loss, but some of those side effects can be much more long-term. So menopausal side effects from treatment, the impact of that, peripheral neuropathy, ongoing pain from surgery. And then there's the emotional impact that patients need to go through, sort of the uncertainty that they're dealt with, anger, anxiety, grief, just some of the emotions that can be impacted in those sort of weeks and months and possibly years after a diagnosis. And then there's the information about practical support, people having to continue working or stop working, their financial concerns, partners, relationships, family members, children and childcare. And then there's just the whole adjustment and adapting to a diagnosis of breast cancer throughout treatment and beyond that. So where do people source their information from? Now, healthcare professionals really is the key one when they're at the start of their journey. Google can be brilliant, but also can be a complete minefield. People can go to family and friends for further support, local cancer information services, support groups in person and online. Obviously, the focus that I'm going to be focusing on today for the talk is charities, national and international charities as well. And social media plays a big part as well. That can be good and it can be not so good as well. So there's a whole host of places people can go for information. So it's understandable that with the amount of information that is needed through their treatment diagnosis and the sources of information they can get there, it can lead to a complete information overload. And some of that information can be trusted and some of it not so trusted. So it's really important to find out where people can go for that trusted information and support. So really the importance of patient-focused information is because the treatment pathway is becoming so much more complex. There's multiple treatment options to consider. Individuals want more information that they wanted many years ago. Clinical nurse specialists and healthcare professionals have got increasing workloads and less time. And I think although it's not in order, COVID has played a massive part in that. Face-to-face appointments are much less than they were before. And so that can be a barrier to the amount of time you're actually spending with your healthcare professional and your clinical nurse specialist. And the digital age that we live in, there's information at our fingertips. So it's knowing where to go for that trusted information. So benefits of seeking out appropriate information leads to increased knowledge. It can reduce anxiety. It can help the individual feel more in control. And it helps you to know what questions to ask and help you feel more prepared. So I'm going to talk a bit about some of the services that we offer here at Breast Cancer Now. We are a UK-based charity. We merged, for those of you who are sort of UK-based or much more international, we merged with a charity, Breast Cancer Care, and formed Breast Cancer Now back in June 2019, becoming the largest, most comprehensive breast cancer charity in the UK. The information we offer is specific to what is available currently in the UK. And although people can access our information from our website internationally, a lot of the services that I'm going to talk about today are specifically available to people that are based in the UK. If there'll be certain ones that will be people can access overseas, but the majority of the services are for those living in the UK. So our helpline is manned by an amazing team of dedicated nurses. I feel very privileged to work with some really fantastic nurses. It is open 6 days a week, Monday to Friday, 9 till 4, Saturdays 9 till 1. It's free from UK landlines. And it's a free and confidential space, really. We provide information that's tailored to the individual. And it's a safe space to talk, really. And when I was a nurse specialist working in the NHS, I often felt quite protected of my patients and didn't really want to sort of suggest that they go elsewhere for support. When I first started working for Breast Cancer Now and saw what a resource our helpline was, we have the luxury of time. We don't sort of have clinics we need to run off to. We're able to spend up to an hour or more in some cases if it's needed with individuals who call us. And the types of call we get are really varied. And sometimes it's that they don't want to bother their team or they don't know if it's the right query to bother their team with. And other times it's just that they're out of their hospital-based treatment and they've got ongoing concerns. And sometimes it's a listening ear. With the impact of COVID, we also found that our calls to our helpline did go up. And I think the sense of isolation and feeling alone at that time, so calls to our helpline did go up and continue to be higher than they were on previous years. So yeah, so that's really, and from there we can obviously then signpost people on. And I'll never forget, once I knew the services of breast cancer, now the helpline is giving a diagnosis to someone on a Friday, knowing that there wasn't a nurse available at the weekend to be able to speak to that person, and knowing that I could signpost them to the helpline on a Saturday morning. They may not be able to give that individual the clinical information, but to be there and to listen to that individual when they had worries and concerns was really vital. So our Ask Our Nurse email service is, again, something you can access on our website, and you can ask any questions. These are sort of set some of the set topics. To do now, service went up with the pandemic. We had lots of queries coming in, and that continues to be much higher than it was before. Can everyone hear me? It's just saying my internet connection is unstable, but hopefully everyone can still hear me. So again, that's a place people can contact us and ask any question that they want. We aim to get most responses back within 3 days. I would say the majority of responses are much quicker. People can also post a question via Facebook, Instagram or Twitter, and we will respond to that as well. We do get overseas contacts via our Ask Our Nurse email service. Again, we will reply to overseas queries. It's much more difficult because we can only be specific about the services we offer in the UK, but certainly we can signpost on to support that may be relevant to the country that they're contacting from. So our website and publications, we have a whole host of information on our website that is accessible to anyone, which is regularly updated. Again, with our publications, they can be downloaded from our website. And again, if you live in the UK, you can request those and they are free. They are updated every 2 to 3 years, depending on the content. And they are reviewed externally by clinical experts as well. And again, if there's topics, i.e. just thinking of COVID, where things that are new or new treatments that are emerging, once they're approved, we will update our information and add that to our website. We also, which I'll come on to later about the Facebook and Instagram lives, we embed our specific Facebook or Instagram lives that are relevant to the topic into our website as well. So that's another way of accessing further information. And our information goes right through from breast awareness to treatment, to chemotherapies, to breast reconstruction. As you can see there, one of the titles to body, intimacy and sex, diet and breast cancer. We have a whole host. And again, if you go onto our website, you can see our full list of publications that are available. So our forums offers a safe space to talk to individuals online. You can connect with people who may be going through similar things, post questions. It's available 24 hours, 7 days a week. It's moderated. So it is a trusted place that you can go. You need to register to post online, and your first post will be sort of read before it's posted via the moderator. Again, for more tricky questions, they will come back through to our nursing team and we will respond to those. And we aim to respond to most forum posts within sort of 24, 48 hours. Our Facebook, Instagram lives and podcasts. Our first Facebook live was back in February 2018. And it's run by, we either have sort of Q&As with our nurses, or we invite experts, patients to talk about a whole range of subjects. And I would say that from the start of the pandemic, this was a way that we really found we could reach people much more easily than when all the sort of face-to-face services were halted at the beginning of the pandemic. And I'm proud to say that as of this week, we did our 100th broadcast. We've reached 1.74 million Facebook views and 102,000 Instagram live views. And Facebook has highlighted us as an exemplar of good practice for our Facebook lives. Again, we try to make these relevant and topical. So at the beginning of this year, when the vaccines came out, we saw an increase of calls to a helpline with uncertainty, queries, concerns over the vaccines. And so we linked in with an oncologist and did a Facebook Live based on the topic. And that was really well fed back. And I know Liz, who's on the panel, has done quite a few Facebook and Instagram lives with us, and they've been really well received. And all of our Facebook lives and Instagram lives are downloaded to YouTube. So they're accessible. So you don't need to be on Facebook or Instagram to access those. And we certainly signpost those people to those from the helpline. So we have a brilliant one on menopausal symptoms, sex and intimacy, ongoing side effects from endocrine therapy. And they're really good resources for people to watch. Our diet and breast cancer one, again, has huge amounts of views. So, and that's something that, again, I think is a way of reaching out, and we get really good comments and feedback from our Facebook and Instagram lives. So our services, moving on to those, our Someone Like Me service is a peer support service. So it's for anyone with a diagnosis of primary breast cancer. And we have a whole host, I think we've got just over 200 volunteers, and they're trained volunteers to support somebody going through a diagnosis of breast cancer. And their way of support is either via email or talking on the telephone. And they are matched. So somebody would be matched to a similar age, a similar type of breast cancer, similar type of treatment. And again, something I very much used to signpost to in my days when I worked in the NHS. So somebody may have been offered 2 types of breast reconstruction and are sort of finding it quite difficult to come to sort of decision as to why they should go for one or another, and talking to somebody maybe who's had both options and sort of talking that through. Now, everyone's experience of breast cancer and their treatment will be individual to them, but just being there and being able to talk to somebody, listening, offering some emotional support and sharing their own experience can help in that decision-making pathway. And I've just included a quote here from somebody who used our Someone Like Me service. I feel so much more positive and less afraid. I know that there is always someone there to talk who isn't as connected to me, so I don't feel I have to hold back. She cheered me, calmed me each time we spoke. I will never forget her or her help. And again, so we've just sort of, if we get somebody on the helpline and we're not quite sure, we have an amazing team who runs that, and we can drop them a quick email. So again, if there's anyone listening, they're not quite sure, we can always check out if we've got a volunteer. Our volunteers, we try to recruit to on a yearly basis. So the volunteers are sort of accurate and up to date. We have men with breast cancer as part of our Someone Like Me service. We also have family members. So again, for husbands, wives, partners, children, sort of siblings, that they can talk to people and support those as well. So our younger women, so going to sort of, I suppose, patient-focused resources, younger women we know have sort of their own unique needs, and whether that's sort of dealing with fertility, children, work. So we have specific resources for women under the age of 45 that we offer. We have our publications and our website information. We also have our Younger Women Together, which unfortunately, due to the pandemic, was a 2-day face-to-face event for young women to meet up and listen to talks, but come together and network and support one another. Unfortunately, that stopped back in March 2020, and we moved that quickly online. So currently, we offer a combination of sort of online, so it's a closed group. It's not the same as face-to-face support, but it allows women for the time being. Last month, we went back to our first face-to-face event, and currently we're doing it as a 1-day event, and we're looking at how that runs. But I think we're going to do a sort of a hybrid of keeping out online, because again, we reach out to a much sort of wider audience, but also those face-to-face meetups are really, really good. We also have Younger Women Together speakers live. So we'll have specific topics where we'll have an expert guest speaker coming together to talk about menopausal symptoms, diet and breast cancer, work and cancer, just a sort of a flavour of some of the things we do. And again, going back to the Someone Like Me service, it's something that we do signpost back to. And again, there's lots of amazing organisations out there, smaller charities or people on Instagram that have a following. And there's a closed group, there's a younger women, Younger Breast Cancer Network, which is a closed Facebook group that we often signpost a lot of our younger women to, which is another amazing resource. And again, I won't read out the quote, but it's there for you to have a read of. Our secondary breast cancer support, again, we did have face-to-face meetups, which were suspended due to the pandemic, and we currently offer an online program and virtual meetups for those diagnosed with secondary breast cancer. We have publications, our helpline, and our Ask Our Nurse. Our Living with Secondary Breast Cancer meetup groups are starting to come back again, and again, that's sort of like regular meetups face-to-face with individuals, with a facilitator to allow that group to happen. And we have a Younger Women with Secondary Breast Cancer support. That's suspended face-to-face again because of the pandemic, and we're hoping to get back to that sort of probably at the start of next year, but we have the virtual meetups. And I'm hoping this works, but I just want to give you a flavour of what our online programme offers. So I'll just see if I can play this.
There is no audio on it, Louise.
Is it not working?
It's working, but there's no audio. Just raise the volume on.
Okay, I'll raise the volume. It's working.
And still no audio on it.
No. If it's not going to work, I wasn't sure if it would work. I was hopeful it was.
The video is working, but the audio is not working, unfortunately.
Yeah. Okay, we'll leave that. But it just basically explains a really nice sort of, rather than me being prescriptive of how the program works. But it's a range of pre-recorded videos that people can watch in their own time, but also a closed group that they have a chance to connect with other people and speak virtually. And a chance to, again, talk to our nurses and post questions and get answers to our nurses. Cool. So our moving forward course, again, due to the COVID pandemic, this was a face-to-face service that we offered and linked in very much with hospitals throughout the UK. And it was a 4-week programme where people could go and have had a group facilitator and meet with other people who'd come to the end of their hospital-based treatment or were within 2 years of their primary diagnosis. We very quickly moved this online. So we managed to do that very quickly in the early sort of months of the pandemic. So really there was a very short gap where this was not offered. And currently the programme offers, again, a pre-recorded videos with topics including diet and breast cancer, activity and energy, managing menopausal symptoms, risk of developing lymphedema, breast and body awareness, sort of dealing with sort of fear of recurrence, adjusting and adapting after treatment. It's a closed group. It's a chance for women to connect with one another. And we also do a live Ask Our Nurse session. So they get an hour with one of the nurses, literally just to sort of fire questions in a closed meeting room. We do also have a publication there as well. We are hoping, and we are in the process again of connecting with hospitals to get this back, and we do feel that a mixture of online and face-to-face is, and that's something that we do here on the helpline, that people really miss that face-to-face connection. So our Becker app really goes hand in hand with the Moving Forward programme, and it's a chance for people to sort of listen to blogs, stories, hints and tips, adapting to sort of any sort of after breast cancer treatment and as well. And I've sort of proudly put that we did win a National Lottery Award for the Becker app. So that's a really sort of accessible and can be downloaded, and that's constantly updated as well. So I just wanted to give a big shout out. I know that in the UK we are a big charity, and as a nurse sort of working on the helpline, there is sort of really good resources and support out there, and we often signpost. So we do offer a whole host of support that I'm really proud of and to be part of as breast cancer now, but there's cancer hair care for people going through treatment who have lost their hair, which is an amazing charity. The Fruit Fly Collective has a huge amount of resources for parents to talk to children going through a breast cancer diagnosis. Keeping a Breast is another one for people who are having breast reconstruction. And then there's the big ones, Macmillan, Cancer Research UK, Maggie's, and just a big shout out to Facebook and Instagram Live, who have a whole host of good resources that people can access. And again, we will signpost to when we know about good things. We certainly will sort of shout from the rooftops, because although we offer a whole host of resources, we don't do everything. And really, I think it is about sort of letting people know what's out there and what's trusted and what they can go to for support. And I think before I finish off, I just want to sort of give a shout out to what we have available for healthcare professionals. I mentioned about reviewing our publications. We're always desperate for any healthcare professionals who would like to review our publications, who are based in clinical practice. It's a really good sort of process to be part of. I certainly did it as a nurse specialist when I worked in the NHS. Our Younger Women Champion group and our secondary breast cancer nursing group is an opportunity for nurses to come together across the UK and share good practice and highlight issues that are pertinent to patients. And one of the key areas, I know, again, I was part of the Younger Women Champions group before I joined Breast Cancer Now, and we got the fertility toolkit. So it was streamlining the process for younger women to get fertility brought in as a topic of conversation. And if anyone's interested in doing any webinars or Facebook Lives, I know Liz has done many with us, please do let us know, because we're always looking for anyone who's willing to come and talk to us. Thank you for listening.
That's great. Many thanks, Louise, for this. And I know there's lots of people online that are doctors, and there's some patients online. This is not only important for patients, it's also important for doctors. Those resources are not available everywhere. And we have people, I think when we looked at one of the webinars, we had people logging in from more than 100 countries around the world. So you can use those resources for your patients, and which is great to share those resources, because many people end up going on Google and going to the wrong websites, and they come with some real and wonderful ideas that we don't want them to have. So it's great to have that talk. Many thanks for that, Louise. We'll take all the questions at the end, but there might be some questions on the question and answer section. So if anybody has anything for Louise, go on the question and answer section. We'll be happy to answer all those questions there. The second speaker is Giuseppe Catanuto, and Giuseppe has been always on those webinars, either attending or talking, and it's been a pleasure working with him for the past year or so. And Giuseppe is from Catania in Sicily, and he's one of the part of the group Greta from Italy, who does lots of wonderful work. And he's going to talk to us about shared decision making. Giuseppe, the next 15-20 minutes are all yours.
Thank you very much. Good evening to everybody from Sicily. Thank you, Yazan. It is a great pleasure to be here. I really enjoy these webinars, either as a speaker or as a participant. And I'm going to share my screen. And today I'm going to talk about shared decision making, which is one of the most important, one of the hits we can say of Greta, of our team, is one of the most important tenets of the surgical philosophy of our founder, Maurizio Nava. And probably you have already followed one of my talks about shared decision making, because we organized, as already mentioned by Yazan, this with Senator, with other societies. Today I'm going to talk about the gaps in applying shared decision making to everyday practice in oncoplastic practice. And before talking about shared decision making, we have to talk about decision making in surgical oncology of the breast. And you can see easily in this slide how the decision making process has become even more complex during the last let's say 40 years, because at the beginning, in the 70s, patients affected by breast cancer had only one chance, mastectomy. And then we had breast conservation, then we had breast reconstruction, and that at the beginning, by the end of the 90s, we had oncoplastic surgery, and then more complex breast reconstruction, and then multidisciplinary treatment of breast cancer that is integrating post-mastectomy radiation, neoadjuvant chemotherapy. So the decision-making has become even more complex. And what we did with the team of Greta is this international Delphi survey that was including some of the most important senior key opinion leaders from all over the world that were interviewed using narrative interviews about features of decision-making, and interviews were analyzed using techniques of artificial intelligence and natural language processing. And you can see that when we interviewed the experts said that we are dealing with complex decisions. So if the experts are talking about complex decision, when we are doing decision making, you can imagine how complex it could be, shared decision making. Regarding the tools we decided to use, about 4 years ago, when this paper appeared on the BMJ, this paper from the team of Glyn Elwin and Marianne Durand from the Dartmouth College in the United States, we decided to use this model, that is the 3-talk model. The 3-talk model is an iterative conversation based on a circular model in which we have 3 steps: and team talk, in which we discuss with the patient, we create a team, and then a second talk that is the option talk, in which we introduce all the possible options, all the surgical options we have. And then the final phase, which is the decision talk, when we hopefully we come to a decision that should be a shared decision. This is not a linear process. It's not step 1, step 2, step 3. It is a circular process in which you can create the team while discussing with the patient the different options. You can discuss option while going to the decision phase. And well, at least in our work, we believe that the team talk, which is the first phase of the 3-talk model, should begin before having the diagnosis of breast cancer. The first time you see the patient in your consultation room, you need to start with the team talk because you meet the patient for the first time, and you probably already know that she will have breast cancer and she will need your treatment, but you have to establish a team with her, explain her that you will be her surgeon, and talk about your team, introduce details on your skills. I'm an oncoplastic breast surgeon. I do breast reconstruction. I do oncological operation at the same time, and I will need to investigate not only conditions related to the present disease, but some other personal aspects and so on. And we go to the first gap. The first gap is that when we meet the patient for the first time, eventually we are going to violate the social distance, which is quite something tricky if you want to establish a peer level relationship with the patient, because you touch the breast, you touch the body. Sometimes you touch the body in other parts because you want to see if she has fat areas, if she's obese, if she has donor sites in the back, in the abdomen, and so on. And you take measurements, you take pictures, and then you start discussing maybe some personal issues and sometimes painful issues such as a family history of breast cancer and so on. And when you meet the patient for the first time, you are violating the so-called prosemica. Prosemica is the distance, the social distance, reducing the distance up to 0 to 50 centimeters. You are entering in an area of intimacy with the patient. And when you meet somebody for the first time, and this one is talking to you undressed, and is also violating the intimacy distance, well, it is not very easy to have a peer conversation in this situation. So we know now that the patient has breast cancer. We have got the diagnosis. And we start the conversation again in our office. We step back, we tell the patient that we know that she has breast cancer. It is time now to think about the most suitable treatment for her. And we offer an alliance, we offer choice. We explain to the patient that we can treat the disease, but she has multiple choices. And because everybody's different, we want to involve her in this decision process. And sometimes in this phase, patients are very keen to stop the process and say, okay, you are the doctor. I don't want to discuss all these issues, too complex for me. Please take your decisions, do my best, and so on. And you need to try and defer closure at this time, because obviously you want to involve your patient. Okay, give me a chance. I want to involve you in this process because, believe me, this process is going to improve the results of your treatment, improve the results of quality of life after treatment. And then and here we have gap 2, which is again a huge imbalance in the relationship. This picture is a courtesy of Glenn Elwin. So if you look at this picture, you have a man on one side wearing glasses and reading a sheet of paper. On the other side, you have a woman who is the doctor and who is the patient. So if you ask to patients and doctors, they are, most of the times they will reply that this one is the doctor and the other one is the patient, which is exactly the opposite. This is the doctor and the other one is the patient. So you see how much prejudice you have to fight when you are entering in a relationship as a patient with a doctor, and the other way around, as a doctor with a patient. And especially in the field of breast cancer, where most of the times the doctor is a man, and on the other side, most of the times there is a woman. And so what can be the action that you can take in front of this situation? Well, first of all, as far as gap 1 is concerned, you have to respect the dignity of the patient. So use chaperone. Don't touch the patient if not needed. And do not allow anybody else present in the room to touch the patient. It is very uncomfortable to feel anybody else touching you. No matter, it's not a matter of sex, if it's a male or a female touching you. Do not allow members of your team, anybody with you. And try to keep the distances, because you can respect the prosemica and stay 50 centimeters far from the patient anytime. Try to respect the prosemica. And then you need to act against the gap 2, improve the communication style. Ask open-ended questions, have a warm disposition, encourage emotional expression. It is something that, well, normally surgeons are not trained on. They do not study these kind of things during academic courses. And then there is something else which is very important. Try not to be dominating in the conversation. There are a couple of very interesting studies using, again, techniques of natural language processing analysis that are demonstrating that most of the times there is a dominance of the doctor in the conversation. And okay, the doctor is explaining a lot of details of the disease, but the doctor has to make the so-called preference diagnosis. And to do preference diagnosis, the doctor should be able to listen to the patient. This is very important. And again, it could be quite helpful to use self-disclosure. Maybe you have been a patient, you have been a cancer patient. Sometimes it happens. Maybe you had a relative with breast cancer. So don't be afraid to expose your personal feelings, your personal situation with the patient. There is no reason. It's not a matter of professionalism. You can be professional, even telling about your past personal, familiar history. There is no worries about this. And this will increase the patient's trust in you. The intention to disclose information, you will rebalance the communication process. Don't forget that you are talking to somebody that maybe is half naked in front of you. So it's an absolutely unbalanced situation. And this will increase the desire of the patient to continue to communicate with the patient and express feelings, express preferences and values. And then at the end, create empathy. Empathy is something that is not very easy to train. If you are an empathic personality, well, it is quite easy, but if you are not, it is very, very difficult to get empathy with your patient. But anyway, this is another important dimension which is often underestimated, underemphasized in the training of surgeons and physicians, generally speaking. And then we move to phase 2, that is the option talk. So at this time, you have to check the knowledge of the patient. What have you heard about breast cancer? there is a bombing today of information. They go through the internet, they watch videos on the YouTube, they go in the social media and so on. And then you have to understand what is the real level of knowledge of your patient. And then you start listing options and describing options, and then possibly offer to patient decision aids. And we've seen a huge amount of decision aid in the very nice presentation that Louise did before my presentation. And we also developed in Italian our decision aids that are visible on the website of Maurizio. And then finally, the final phase is when you summarize and you try to expose all the possible chances and try to understand if everything is clear to the patient. And then we go to gap 3, and it's complexity. I'm sure you remember that complex picture that I've shown at the beginning. I'm going to show it to you again soon. The options are multidisciplinary, and you are a surgeon, and the patient is going to ask you about radiotherapy, about primary systemic treatment. Try to keep the language as simple as possible. And I'm not sure that having with you other specialists will simplify this process. And then there could be some difficulties in understanding, because most of the times the doctors like to use complex medical language. But you can have a professor in front of you and she cannot understand because maybe a professor of surgery, but she's a gynecologist, she's a general surgeon. She doesn't understand anything of breast surgery, maybe. And then sometimes you can have socioeconomic barriers. You can have poorly educated patients that are not even able to understand the language. It may happen sometimes. And then there can be, but this is a problem of the doctors, reluctance to refer for not available options. I'm a breast surgeon, I do oncoplastic surgery. In my unit, they don't do a DF flaps. I'm not going to offer this option to my patient because I don't want to miss my patient. And obviously this is not fair. And finally, there could be some options that are not available due to the contingency. It is something that we experienced during the COVID-19 pandemic, or maybe in the complex organization of public systems where we are now working. I'm working, for instance, in Italy, or maybe in the United Kingdom, or in the EU in general. What is the action that can be taken against this gap? Well, first of all, be pragmatic on communication. It has been demonstrated that we normally face approximately 14 decisions during a single consultation. If you want to discuss every single decision, well, you will end up in a paralysis by analysis. You will not conclude your process. It will last hours. And be very accurate in identifying what really needs to be discussed. And this is the complex graph that is representing the multiple options that you have when you practice oncoplastic surgery. It's such a huge amount of techniques that you can use. And then on the other side, you can see one of the most useful, is a validated tool, a validated decision aid that was developed by Glyn Elwin and team, is the option grid, which is a very basic tool. How can you translate this complex information into this very basic tool? This is a discussion that we had with Glyn. And the conclusion was that you can start the discussion from the very simple decision aid, and possibly you can deepen it using other decision aids, or maybe just conversation with patients, or direct interaction, or any other kind of decision aids, maybe not validated, that could be relevant to this process. And for those patients who live in low-income countries, or who have low social and economic conditions, it has been tested and validated, this other decision-making tool by Marianne Durand. She performed also a randomized trial, demonstrating that pictures can be helpful, especially in this subset of population. So you can use also the picture option grid, which is very helpful. And this is a decision aid, a very simple decision aid that we designed, but unfortunately we never tested it in clinical practice, that is combining in quite a simple way the information related to oncoplastic surgery in a very simple tool. We never tested it. It could be helpful. It is something in the middle that may provide some good information in comparison to the basic option grid. And then we need to move to the decision talk, the final phase. And we need to analyze patients' values and preferences. And you have to tell to the patient, I would like to understand from your point of view what matters most to you. And then elicit a preference and then move to a decision. And finally, this is very important, and we will see another gap on this final topic, offer possibility to review. Okay, gap 5 is how we, as surgeons, we can assess values and preferences. Okay, we may assess surgical values in quite a straightforward way, and I'll show you later. But it is very difficult to understand personal values. And don't forget that we are talking about the breast, which is a very important organ in terms of intimacy, sexual relationship, personal gender identity, and so on. So it is very difficult for us to go through personal values and understand these and translate these in surgical techniques. And we rely on breast care nurses. I've started my career at the Royal Marsden with 2 fantastic breast care nurses, and I'm sure that it is something that it is in my background for the entire career. And I may advise regarding surgical values to create semantic patterns. What does this mean? Try to translate surgical techniques into the effects of surgical techniques, and then create patterns, semantic patterns. Just try to understand if your patient is happy with minimal asymmetries, for instance, or she wants minimal scarring, or maybe she wants a unilateral operation. Well, in that case, you can talk about minimal aggressiveness, and then translate this to the surgical technique. Don't use complex jargon, such as inferior pedicle breast reduction, superior pedicle mammoplasties, perforators, flap. Nobody can understand except for a breast surgeon this terminology. This is quite clear. And this is a very nice tool that was introduced about a decade ago in a trial by colleagues from Toronto. It is a very nice cognitive exercise to understand patients' values, but it is also on the surgical side. So you can ask the patient in this kind of Likert scale, do you want minimal scars on other parts of the body? Do you want the lowest risk for very serious complications? Well, it's something that can help you in understanding surgical values and what to do in terms of surgical technique. And finally, gap 6, which is one of the, it's a very tough gap. Give time and offer review, especially when you are making your surgical, your theater list. When you are so busy, it has been demonstrated by this group of colleagues in Germany that as soon as a patient receives the diagnosis of breast cancer, it takes about 15 minutes to leave your consultation room. And this is very, very narrow time, 15 minutes to explain such a massive load of information regarding disease, regarding techniques, and so on. It is a minimal time. And I think that we need to allocate resources to expand this time for such an important disease. It should take at least 1 hour it takes at least 1 hour in my practice. And you can use some tools, very useful tools that are now under testing, such as pre-habilitation or pre-consultation educational group, or maybe other techniques such as webinars, such as videos on the YouTube, decision aid tools. These are very well developed and can be very helpful to get to a decision. And finally, once the decision has been taken, it is advisable to evaluate and to check if the process has gone well. And to do this, you can use the Collaborate tool. Again, this is a tool from the group of Glyn Elwin and Marianne Durand. It's a very frugal questionnaire made up of 3 questions, very easy, that we tested on a small population of about 60 patients in our unit in Catania. And you see the results are quite reassuring, although we had some problems with the language, with the translation, because at the moment we haven't gotten an official translation in Italian. But using tools for assessment of your shared decision-making process can allow you to see how the situation is going, to refine your skills and to improve. So in conclusion, these are my suggestions for the implementation of a formal shared decision-making process. First of all, use formal models. And we like the 3-talk model, but there are so many others. And go through the literature and search and identify what fits better with your everyday activities. Use validated decision aids. I do acknowledge that sometimes they can be very basic, but you can start from that and then go ahead and using something more complex. And then again, assess the results. And finally, try and contribute to improvements. This is the only way to put the patient at the center of the decision-making process and to develop this very important phase of the surgical process, because I'm convinced that shared decision-making is part of surgical skills. Okay, I go to a conclusion. Thank you very much for the attention. And I want to invite all my colleagues to attend the next MBN 2021 Oncoplastic Breast meeting. That will be an hybrid meeting and will be held in Milan in presence and online. Thank you very much for your attention.
Thank you very much for the great talk, Giuseppe. As usual, it's great to hear about the gaps in decision-making from your point of view, and it's a great work that you have delivered. And now we have the last talk before we go to the discussion. There's few things on the question and answer section. So Louise and Giuseppe, please do have a look at that, see if you want to answer those. But the next speaker is Liz Oridian, and Liz was one of the surgeons in Ipswich, and she's known as the breast surgeon that had the breast cancer, has been very vocal about it, has shared her stories on social media, has a book, which is the Complete Guide to Breast Cancer, How to Feel Empowered and Take Control. Please have a look at that on Amazon. You can order it. I always advise it to most of my patients that come to clinic. And as I think is writing her second book, which is coming out hopefully soon. And we're going to share today is the talk that she gave in the American Society of Breast Surgery, which was held a few months ago, about the little things that matter. So I'm going to share the screen now, and we'll play the talk by Liz. If there is any problems with the screen sharing, please let me know. Share.
Hi, I'm Liz O'Riordan, and it's an honour to be able to talk to you today. I'm only sorry I can't be there in person. What I want to do today is share with you some of the little things that can make a massive difference to the care of every single patient you look after. But why am I that person to tell you how to change care? Well, this was me 5 years ago. I was a consultant breast cancer surgeon in the UK. I think that's your equivalent of an attending. I trained for 20 years. I'd done a postgraduate diploma in oncoplastic breast surgery, and I had a folder stuffed with all the latest papers and research and evidence on my computer. I thought I knew everything. And I prided myself on giving a high quality service for my patients. And for me, that meant doing the right thing to the right person at the right time, leaving invisible scars around the nipple that nobody could see, making sure I had the lowest possible number of complications. I even had women come up to me in supermarkets and flash their breasts because they were so pleased with the scar. I thought I was the best. And then I realized that I knew absolutely nothing about breast cancer. And that was because in 2015, at the age of 40, I went from being a fit, healthy triathlete to a stage 3 breast cancer patient overnight. I was going to have every single treatment I prescribed my own patients, and I realized I knew almost nothing about breast cancer. Now, I'd had a cyst 9 months before with a normal mammogram and ultrasound, and I thought the new lump in my left breast was just another cyst, and I wasn't worried about it, but I mentioned it to my mum, and she asked me to get it checked out because she was worried even if I wasn't. My mammogram was normal and I had an ultrasound. And because I do scans myself, I turned to look at the screen. And the moment the radiologist put the probe on the breast, I knew I saw a large cancer. And because it was large and I was young, in that split second, I knew I'd need chemotherapy. I knew I'd need a mastectomy. I had a good idea what my 10-year recurrence rate would be. I knew too much. My husband knew none of it. My parents knew none of it. I didn't know what to do with that information in my head. It was just too much to handle. The ultrasound showed a 2.5 centimetre tumour, and a biopsy confirmed it was a mixed ductal and lobular, ER positive and HER2 negative. And because it was mixed, I had an MRI, and that showed it was actually closer to 6 centimetres. So because of that, I had neoadjuvant chemotherapy up front to try and shrink it down. Now, I've lost count of the times I've sat in meetings and glibly prescribed chemotherapy to patients. The algorithm says there's a 5% benefit, yeah, give them chemotherapy. I never see patients during chemotherapy. I see them either at the end after neoadjuvant to discuss surgery, or the oncologist deals with them. I had no idea what it was really like to go through that treatment. And I was about to find out, and I was scared and anxious and terrified. How bad would it be? And I felt so sorry for myself, sat there the first day in the chemo suite, because I was the youngest patient there by a good 20 years. And it was just that fear of the unknown and not being in control. I knew I was meant to feel ill, but just how ill would that be? I also knew that chemo made you lose the hair in your head, but I didn't know that you lost all your body hair, free leg wax and bikini line wax. Who knew? I couldn't believe I didn't know that. The constipation, the bleeding piles, the loss of fingernails, pride, dignity, infertility, the mental brain fog, you can't think. It was just horrid. But I can't remember any of it now. It's almost like your brain just switches off the trauma. If I have a bad hangover or a bad cold, I'm straight back there, but I can't actually remember the details, thank goodness. And best of all, it worked. My final MRI showed that my cancer had completely disappeared and my nodes were negative as they had been at the beginning. But because I was small-chested, I went to have a mastectomy. And that was a really, really hard decision. This is a ridiculous selfie of me smiling for my blog before I'm about to have my left breast cut off. And the surgical decision-making was really, really hard for me. I had the luxury of 5 months of deciding whether to have a reconstruction or not. A lot of my patients would normally have 1 or 2 weeks because I have to treat them within a month. And I wonder how many women in the audience think about what their breasts mean to them on a daily basis. It's only until you're faced with the decision of losing one that you suddenly have to confront how it affects your femininity, your sexuality, your body image. And it's impossible to think rationally when one of them has cancer. I chose a reconstruction for 2 reasons. And one was vanity, which I felt really guilty about, but I wore a lot of low V-cut tops, and the thought of wearing a big bra with a prosthesis in, I just couldn't handle it. I also stupidly thought, what would my patients think if I didn't have a reconstruction, but I was offering them one themselves? So I had an implant under the muscle with a mesh, and it went well. But it was really hard for me deciding which surgeon to choose. My own surgeon, she trained me. She was a mentor. She was a friend. I knew she was good. But she worked with my husband, who's also a surgeon, and she told me, I don't think I can operate on you. It's really, really hard operating on colleagues and remaining judgmental. And she asked me, where do you want to go? And I knew almost every breast surgeon in the UK by name or reputation, and it makes you think, who would you choose if you were diagnosed with breast cancer? Do you go for the biggest names in the field, the biggest teaching hospitals, the person who puts up the prettiest pictures at conferences, the best bedside manner? We also know there are people we wouldn't go to for whatever reason, but patients don't have that inside information. I stuck with my surgeon. I trusted her. Plus, it was close to home if there were complications. but I had to learn to stop being a surgeon and just be a patient. I wanted to tell her where to put the scar and what sutures to use to put the drain in. She had to tell me to stop. It was really, really hard giving up that sense of control. But the surgery went well. And I remember going back to get my results, and it was the 23rd of December. And I was really excited this time because I remember looking at the people in the waiting room around me, clutching the floor, hoping that they weren't going to get bad news just before Christmas. And I knew that I was going to get good news because of my scan. And I went in to see my surgeon, and she told me that not only was there 13 centimeters of lobular cancer left in my breast, that 2 of my sentinel nodes were positive. And a light went out in my head again. I didn't listen to anything she said after that because I knew what that meant. I knew just what an impact it would have on my future recurrence. And I had to listen to her talk about, do you want surgery or radiotherapy to your armpits and the future radiotherapy I'd have to have? And it was just all too much. And I was quite blasé about having radiotherapy. I've told patients in the past, it was just an X-ray treatment, you'll be fine. Never really understanding how some of them were just crippled with fatigue, almost wishing they'd had a mastectomy so they could avoid radiotherapy. And I've never actually seen a radiotherapy machine myself. Almost every one of my patients had that treatment, I've never seen it. And I really struggled with axillary web syndrome. We call it cording in the UK. I couldn't get my arm above my head. And my radiotherapy was delayed by 3 months because I couldn't get my arm above my head. And lying in that machine, topless in a freezing cold room, as it went and whirled around me, was just so emotionally painful. I felt lost and alone and fragile. And it definitely wasn't just the X-ray treatment I used to tell my patients. But I recovered and I was doing well. I had physio twice a month to help with my shoulder stiffness and pain. But the one thing that was really bringing me down was pain in my implant, because the radiotherapy had worked its magic and I had a grade 4 capsule, a tight shriveled ball sitting high on my chest, and I would swear out loud in pain because of the muscle spasms. And I decided enough was enough. It was time to go flat. And I saw my surgeon to discuss the surgery, and she thought, let's just do an ultrasound of the scar tissue underneath your armpit. And that showed a 2.5 centimeter nodule of local recurrence. How had I not known that's what it was? I'm a breast surgeon. And suddenly, as well as going flat, I was having further surgery to my armpit, and I had a double dose of radiotherapy to the same area just to stop it coming back again. And the side effects of all that treatment to my armpit meant I had a reduced range of movement to my left arm. And it meant I had to retire as a breast surgeon in 2018 at the age of 43. And I wasn't expecting to stop being a surgeon so quickly, but psychologically, I don't think I could have coped. And this was me about to have my breast taken away for the second time. And I've learned a lot on my journey. And it's really made me think, what is good quality of care? Because it's not just clinical effectiveness, clinical safety, doing the right thing to the right person at the right time. The third factor is patient experience. And you don't get money for doing it well. You can't benchmark against your peers. Every patient will think something different. But I think it's the most important part of the care we give our patients. And it's the thing I knew the least about. And my practice changed so much when I went back to work for a year between my diagnoses. And what I want to do is to share with you some of the lessons I've learned that can maybe help you improve the already amazing care you're giving the patients you see. Google. How many of you, if you were diagnosed with breast cancer or bowel cancer or arthritis, would go to your surgeon's website or your hospital's website? I didn't. The first place I went to was Google. I used to tell my own patients, don't Google, there's scary information out there. I'll tell you what you need to know. And it's rubbish. It's the first place I went. Because although as a doctor, I knew what would happen to me, I didn't know how to cope. I needed to hear from other patients what it would be like and how to cope when it happened. And the problem is anybody can write anything on the internet. There are some fantastic blogs and websites out there, but some really, really scary ones. Lots of people peddling snake oil myths like vitamin C injections for cure metastatic cancer, and you need a turmeric enema and don't drink milk. Patients don't know what to believe. And I had no idea how much information was out there. I'm embarrassed to say that when I was working as a surgeon, I had never once looked at our main breast cancer charity website. How many of you have spent an hour or two scrolling through breastcancer.org to see what information is out there for your patients? How many have read the forums and heard and seen the questions your patients are asking? Because we don't remember anything you tell us in clinic once you say the C word. How many of you know what apps are out there to help your patients control their symptoms, the decision-making guides, the books they can buy? Patients are desperate for information to know that you're not alone and that someone else is going through it with you. I was amazed by the questions people were asking on forums. I remember reading one woman asking, is it safe to have sex during chemotherapy because I'm scared I'll make my husband's hair fall out? And someone else asking, will radiotherapy make me radioactive? There are so many confused patients, and I felt I had to do something about it. And that led me to write this book. It's available on Amazon. And it's the book I wish I had when I was diagnosed, because I bought 10 books. And the professor, the doctor I wrote it with, who had chemo on the same day as me for breast cancer, she bought a different 10 books. We were both desperate to find out what it's like. And we cover everything. How you feel on day one when you find out you've got cancer, the questions to ask your doctor and oncologist to understand the right treatment for you, how to talk to your children, sex, the menopause, diet, exercise, recurrence, depression, anxiety, the whole shebang. And I'm really proud of it, but it's been lovely to hear doctors reading it so they can understand how they can help their patients. And I'm going to go through some of those things with you now today. But I want to start an outpatient clinic, and this is me waiting to go into oncology clinic on my last chemo session. And this is where my practice changed the most when I went back. And it's all about breaking bad news. I remember every single detail of the consultation where I found out my breast cancer had spread, what I was wearing, what the weather was, what the words were said, what I did immediately before and after, how it felt to be in that room. But I imagine for my consultant, I was just the 9th or 10th person that day she was telling they had cancer. You don't give it much thought, it's just routine, cancer is normal, but to your patient, you are about to change their life. And you've had a heads up. You've been in the NDT, you discussed the results, you know what you're going to say, you know what the treatment plan is. But for your patient, it's coming often out of the blue, especially for the screening patients. But patients pick up on little clues. I remember going to meet a woman for the first time who had a second skin recurrence. And before I could say, hello, my name is Liz, she asked, it's cancer, isn't it? And I said, how did you know? She said, you came in with a breast cancer nurse. When it's good news, you come in alone. And it made me think, patients can see breast care nurses coming to get them compared to other receptionists. A friend of my mum's was waiting to get her diagnosis, and in a clinic there were 2 rooms working, and everyone coming out of this door came out smiling, and everyone coming out of this door came out crying, and she was called into this door. If you've never spent time in your own waiting room just to feel the energy and the tension, you don't know what it's like for your patients, and that pent up ball of nerves and anxiety that they feel waiting to come in to see you. And often they've got many questions. I remember when I found out that my cancer had spread to my lymph nodes, I was in severe pain and I was crying at night and I wanted to ask my surgeon. But by the time she'd gone through everything, I just wanted to get out of there. I didn't want to bother her. And I think for a lot of us, our consultations are for us. We write the notes, we do what we need to do, and then we close all the screen down so we ask the patient any questions. And it's such a closed way of working. What if, before you said anything, you asked the patient, what questions do you have for me? So that patient feels they can ask them and you can take the time to reply properly. I think another huge thing at the moment, especially with COVID and the pandemic, is patients can't come with their loved ones to see you, and they're expected to remember everything you've told them so they can then pass it on. But once you hear you've got cancer, you remember nothing. What if we asked patients if they wanted to record the consultation on their phone, so they had an accurate reminder of the consent they've been through and they can then tell their husbands? Now, I'm sure, like most of you, we've all seen the best and the worst of breast cancer. And I used to tell 60-year-old woman with a 1 centimetre small tumour, you know, we're lucky we caught it early and it's good it hasn't spread. Trying to make light that it was a good cancer to have, but no cancer is good and no one's lucky to get it. And I know we want to be positive and reassure them that it's okay. Actually, that patient may think this is the end of the world, and we have to give them that space to come to terms with it. And no one ever hears what you say. The terms and phrases that may make complete sense to you may make women cry when you leave the room. I had one woman tell me that her doctor told her that a terrorist had invaded a hotel in her armpit, and that was his way of saying she had positive nodes. His nurses didn't have the courage to tell him that he couldn't say that anymore, and he was just breaking women. It's really hard to get feedback about the job you do day in, day out, but it's just worth taking a moment to think, could I do it better? And what impact do my words have on the patients I treat? But quality of care doesn't just start and stay in hospital. I think it has to continue when you say goodbye, because we are treating women for 5, 10, 20 years. And the hardest part is when hospital treatment stops and you're left to your own devices. And for most women, that means dealing with the effects of tamoxifen and the aromatase inhibitors. And they can ruin women's quality of life. I'd never been through the menopause, and I used to tell my patients, you know, you'll be fine, just the odd hot flush. I had no idea how bad it can be, especially in the younger women. It's an instant menopause overnight, not the gradual 3 or 4 year slide into it. And as a surgeon, I had no idea how to treat the symptoms of the menopause. I assumed their primary care physician was doing it, but I didn't check. That wasn't my job. And I think I was doing my patients a disservice. The first night sweat I had, I woke up thinking I'd wet myself because I felt a trickle of water running down my inner thigh. I was waking up every hour on the hour, dripping in sweat. I had no idea what to do until finally a friend on Twitter suggested, had I tried citalopram or venlafaxine or clonidine to help? I'd never heard of these drugs, but they could help. Wouldn't it be great if, as well as telling patients what the side effects of these drugs are, telling them how they can treat them, making sure that their primary care physicians are educated and know how to help these women who are suffering in silence? We know anecdotally many women don't take the tablets, and I've thought myself of flushing them down the toilet because they make me feel so miserable. We go through all this amazing surgery and chemotherapy and radiotherapy, but our quality of life is really, really bad. And it's not just the menopausal hot flushes and night sweats that are bad. It's sex. And I've spent most of lockdown talking about sex to cancer patients, journalists, people on Instagram, because it's the one thing nobody talks about, but the treatment of breast cancer can have a devastating effect on women's sex lives. I never talked about it as a consultative surgeon, and I rarely heard my colleagues talk about it. And almost every woman I've spoken to has said at some point they wanted their husband to divorce them, then go and marry a woman with 2 healthy breasts and a libido, because they felt guilty at the damage they were doing to their marriage. And I felt exactly the same. It is awful to wake up when you're young and suddenly have no libido, for sex to be incredibly painful. You never want to do it. Think, is this it? Is this the end of my married life? And it's not all about penetrative sex. There are lots and lots of podcasts that can help patients get intimate without penetration, but for some couples, they need it. And I've had to learn the hard way. And I've talked to an awful lot of women who shared their tips and tricks. I mean, it's not just breast cancer. I know a colorectal cancer patient in her 30s who asked her consultant surgeon what to do with a stoma on a one-night stand. And he looked horrified. And she assumed that the thought of him with a stoma having sex was so horrific, he couldn't imagine anybody wanting to do it. We need to make sure that one person on your team is talking to every patient at some point about the impact of the menopause on their sex life. And there are things you can do to help. And these are 3 of them. The first thing is to recommend dilators to your patients. And I had a bag of tricks with all these things in my clinic that I would give to the nurses so patients could have a look at them in private. If you have vaginal dryness and it's very tight, it's going to be almost impossible to have penetrative sex, and women may need to dilate themselves up. This is a great band. They're silicone, they've got a ring on the end so they can't get lost on the side. You can use them in the shower. They really, really work. The next thing I recommend is lubricants. Now, we can get this in the UK. It has no chemicals, no parabens, because so many lubricants you can buy over the counter are full of stuff you don't want anywhere near your vagina. It's water-based, it's oil-based, for vaginal and anal sex, and it makes things fun. And it should just be part of a normal sex kit for these women, just to help lubricate things and stop things being painful. But the biggest thing you could recommend is vaginal estrogen. When I was a surgeon, I was very, very wary of this. I don't want to give anyone with ER-positive disease extra estrogen. But it's ridiculous, because we know breast cancer comes back in 1/3 of our patients despite full treatment. And a tiny, tiny dose of absorbed vaginal estrogen is not going to have a big impact on that. But the impact it will have on a woman's quality of life is huge, and it should be her choice. And beside that, the dose of Vagifem has reduced from 25 down to 10 micrograms. I'm very lucky. My GP will let me have it every day because I need it. And it's not just for the painful sex, it's the dryness. I'm a cyclist. I'm used to cycling 100 miles. And after breast cancer, I would get labial tears after an hour in the saddle because everything was so dry and painful. This is a complete game changer. And I think if patients are educated and consented, it's their right to say, I would like to have Vagifem, knowing there's a tiny chance it might increase my risk of recurrence, but I will have a happier, healthier life whilst I'm taking it. I want all of you to promise me that somebody on your team will talk to every patient about possible problems with their sex life when they start treatment and things they can do to help. You will do so much good for your patients. The next thing I want to talk about is exercise. I was a triathlete and no one told me to carry on exercising during treatment. I wanted to, it was part of my life, and I turned to Twitter and I found the most amazing woman called Suzanne, who's his athlete on chemo, who has metastatic breast cancer, having Taxol every 3 weeks, who was in the gym and rode and cycled and kayaked, and she inspired me to keep exercising. The one thing every patient I spoke to told me was to walk for a minimum of half an hour every day. And some days I only covered 100 yards, but I'd earned the right to sit on the sofa. The first picture you see is me doing a sprint triathlon halfway through chemotherapy. It was in a local pool and I had a tunneled port so it was safe. And I was one of the slowest people to finish. And I had to persuade them to let me do it, saying I'd stop if I felt ill. But the sense of achievement I felt as I crossed that finish line was just amazing. For those couple of hours, I was no longer Liz the cancer patient. I was just Liz, and I swear chemotherapy side effects were reduced, physical and mental, because I exercised all the way through treatment. A year after finishing treatment, I did a half Ironman triathlon, and that's the picture of me on the other side. And I hate the colour pink. I'm in the wrong job, I know, but I wore pink to raise money for charity, and I did it wearing a big, bright neon pink wig. And it was a 1.2 mile swim, a 56-mile bike ride and a half marathon. And it took me more than 8 hours. Again, one of the slowest people to finish, but I didn't care. I had proved that my body was stronger than I thought and that cancer wasn't going to stop me doing anything. And that sense of achievement, that sense of relief was just wonderful. But why is any of this important? We know that exercise can reduce the risk of recurrence by 50%. 50. When the chemo can reduce the risk of recurrence by 5% in 10 years, exercise can halve it. And it's something patients can do themselves to feel in control. And it's free. They just need a pair of trainers to sprint walk outside, and they can do weights in the home with bodyweight exercises and cans of food. This is an extract from International Roundtable Guidelines for Cancer Survivors, and it says, every single cancer patient should be told to do aerobic exercise 3 times a week and resistance exercise 2 times a week. I bet less than 10% of the audience exercise that much every week. And I wonder how many of you prescribe it to your patients. But there is so much evidence now to show that it should be the fourth treatment for every single cancer patient. The benefits have been shown at prehab, between diagnosis and surgery, recovering from surgery, chemotherapy, radiotherapy, and living with cancer. It reduces the side effects, the physical problems, plus the fatigue, anxiety, depression, and it often just makes patients feel alive and in control again. It is so important. And almost the resistance exercise is more important than the aerobic exercise. One of the biggest reasons the elderly go into nursing homes is because they can't stand up from a chair. And chemotherapy, we know, can cause muscle wasting and fatigue. And if you can get your patients doing gentle exercises at home, squats whilst they're brushing their teeth, push-ups against the kitchen counter when they're making a drink, build it into their day. They can do 5 minutes here and 5 minutes there. It will do them so much good. Seriously, I want all of you to, again, promise that one of your team will make sure patients are told to exercise and told how important it is. We know that the menopause can make patients put on weight. I put on 10% of my body weight, and you can't see it because I'm slim, but it's still a huge gain in weight. Exercise, weights and aerobic exercise can help reduce that and help women get control of their body again, and they're already dealing with body image issues. I was just a triathlete and I wasn't hitting the gym, and I decided it was time to start practicing what I preach. And I spent a year during lockdown at home lifting weights, and it's only now, 5 years old, that I'm finally comfortable with my body and my uni boob, my flat chest. I accept that cancer doesn't define me. It gave me strength, it gave me purpose. And I write about this to try and encourage others to join me and get strong and get fit for whatever the future might hold. But I want to talk about the future, because we know breast cancer comes back in a third of our patients, and it can come back 5, 10, 20 years down the line. You would be amazed to find out how many women think they're cured. They don't know it can come back. They don't know what to look out for. I don't think I ever told patients what the signs of recurrence were. It was a leaflet tucked in a pile of other leaflets that I hope they read. But if they don't know what the signs are, and if their primary care physicians don't know what the warning flags are, especially for lobular cancer, which can be sneaky and present in different ways, we're doing our patients a disservice. Every single woman needs to know, and man, that it can come back. They need to know what to look out for, and they need to know who to see so they can get a scan to check whether it is a recurrence or not. The waiting at home to find out if you have recurrence or not is horrible. We call it scanxiety, that fear. You've got Google at your fingertips, imagining the worst. And if we can educate our patients and empower them, I think patients almost need a CT scan every year just to stop the mental anxiety of thinking, has it come back? And that's fine with me. I don't want people worrying at home. I want them to know if they're worried, they can contact me and I will scan them and sort them out regardless of what it shows. So 3 things you can all do to dramatically improve the care of all your cancer patients. It's to mention exercise at every single appointment. It's discuss the impact of sex with people taking tamoxifen and aromatase inhibitors. And it's to make sure everybody knows signs of recurrence. I like to end my talks with this amazing quote by Eric Topol, who's a cardiologist in the States. And this book is fantastic, talking about how patients are almost becoming doctors with the internet at their fingertips and smartphones. They are almost have as much data as we do. And I think that's a great thing. But he says the patient is the single most unused person in healthcare. And I think he's right. I had never listened to a patient in a conference. Whenever a patient did come up, I would always leave to go and have coffee and network. And all too often the patients were in the nursing sessions. And it was only when I went to an advanced breast care conference run by Fatima Cardoso in Portugal that the breast cancer patients were put in between the keynote speakers. And it would look really rude if you left the room. And I learned so much from listening to these young women in their 30s with metastatic disease. It opened my eyes. Every once in a while, go and read a forum, go and read a blog, find out what it's like to be in our shoes, find out what we really need so you can provide us the best quality care. Why is it so important to listen to the patients? Because you will be a patient yourself one day. Thank you.
Great talk, Liz. It's a great talk, and you can see that from the chat and from the feedback that we have. So before we start the discussion, I will send everybody that has logged in a certificate of attendance. So if you don't get the certificate of attendance, if you don't find it in the next few days, please check your junk mail or spam mail, because the last webinar I issued about 600 certificates and I got 100 emails asking about the certificates. I cannot reply to each email asking to check the spam mail, and each single email I checked, it was mainly issued and was in the spam mail. So you'll get that, you'll get a feedback. There's a survey after we finish the webinar, so please fill in that survey for the feedback. It's very important because I need for that feedback. That's how you get the CPD points for the Royal College of Surgeons. So each certificate you have 1.5 CPD points from this webinar. And now let's go for the discussion. There's lots of things happening in the chat. The chat function has been very busy. I cannot catch up with the chat function. And there's a couple of things on the question and answer section. But let's get Terri and Minas now involved, because Terri is a patient advocate. Terri does lots of great work, and she has the DFC Foundation, which is a website, a charity, and they have a big Facebook group. So if there's any patients and also surgeons and clinicians, please join that. Lots of useful information there, and it's great to have Terri here. And Minas is not only one of the super microsurgeons, he does loads of DF labs. I think in PRMA, they do hundreds of labs. I think the numbers that you can see on his social media are great, but also they do sensation sparing mastectomies. They do lots of new techniques that are not available everywhere, but also he does the Breast Advocate app, which is a great resource for patients and clinicians. So please check that. Now, let's start with Louise. And I don't know, Minas and Terri, is there anything you want to ask Louise? Because I think breast cancer now, breast cancer care, and although the societies and the charities do great work, and as Liz said, people just go to Google. I don't know why, when you have such a huge resource in breast cancer care and breast cancer now on those websites, that is all up to date, always reviewed. Any comments about that, Terri and Minas?
Ladies first.
Thank you, kind sir. I don't have questions. I guess that I will just kind of comment on everything that I've been hearing. I kind of have to take a deep breath, Liz, as you know, after listening to your talk, because our stories align so much. And I had a little PTSD going on. Listening to you. Oh, no apologies. This is what we deal with, right? This is what we deal with, and this is why we are all here today. Just, okay, shameless. Pulled it off my bookshelf while we were sitting here. It's a wonderful book. I'm going to go back to something that Louise said, and it's the word trusted. With everything we talked about today, whoever's on this panel, whether it is surgeons or patients, and I know that there have been some that have joined that are on the private Facebook page, Deep Sea Journey, so I'm just going to wave to you because you've been texting me. I don't know how we get past this idea of Dr. Google and really emphasizing to patients that we need trusted resources, like Louise said. They're out there. They're out there and they're available. I think that what I would like to say is this. If you are a patient or if you are a surgeon of any kind listening to this, I think what we need to tell our patients is that if this feels more like a dramatic blog you're reading or a dramatic group you're in, if they're diving into stuff that just feels like it's more emotion and not evidence-based, cautionary tale. I think what I have heard from my community, when patients receive evidence-based, science-backed information, it immediately, and Louise, you probably find this in your groups, it immediately gives them a sense of control. We deal with enough emotion when we have a breast cancer diagnosis, as you can just see, with Liz's presentation. And so putting the patient back in control, I guess that would be my message this morning, is to let patients know that if this feels like science, if it looks like evidence-based information, those are the resources that you should go to. And Giuseppe, you taught me a beautiful word today. I'm going to see if I can pronounce it properly. Proximity? Okay. That to me it's almost the dance that patients go through with the surgeon when they are in consult, because that is based on a patient's prior experience, but it's also based on culture. It's based on what their emotional level is at the time they go into a consult. All that social awareness in a consult is so important. I'm so glad that you talked about that. But there's something that I want to emphasize that I really liked in your talk. And that was step one, that team talk that you talked about. Because in my instance, I was so fortunate. I was so fortunate to have a breast surgeon who empowered shared decision-making. And then I switched right over to Dr. C, who just, spreads it out to the world and taught me even more about it. I think what is important in this team talk is that we include, before a patient receives a diagnosis, you include a team who can give you options for surgery. And you can talk about that, because the day that I went in to find out if I was going to have an amputation of my breast, I just thought I was walking in there for that. But that day she told me about all my options for reconstruction. So I went in there angry. I was angry, I was emotional, I was depressed. I left there with a sense of hope. So I think that team talk that you talked about is very important. I would encourage those who are listening, if you're a patient, if you're a physician, add that into your consultative practice to do that team talk. I think that's really, really important. And encourage patients to find trusted resources. Dr. C's Breast Advocate app, it's available everywhere. It's free. Use trusted resources like that. So that's my word today. I'm happy to take any questions from the panel, but I had to kind of wrap up, everything that everyone has said here to let those who are listening know the power of this education that's being presented today, because as you said, Liz, education is the empowerment of the patient. Louise, you talked about it too. Dr. C, you developed your app for that. Gazan, Giuseppe, all of us here on this panel, that's what brings a patient empowerment and brings them a sense of control and buy-in in any decision they make, whether it's for treatment or any type of surgery. I will leave it at that. And thank you for inviting me today, Evan.
Thank you very much, Terry. And it's very important to know that out of the 400 people that were online, maybe 100 or 200 will be from Europe and the western part of the world. There's lots of people, if you notice, and when we started, they say good evening from Myanmar, or good evening from Venezuela, or good evening from other health systems that might not have everything that is available for us. But at least if you have the website like the Breast Cancer Now, or if you have the Breast Advocate, if you have the information from Macmillan, at least they will have the knowledge, and that will empower them to make decisions, because sometimes that might be a life-changing decision for them. Minas, any words about your Breast Advocate app? Because I think it's a great app.
Oh, thanks, man. I appreciate it. Thanks for the invitation to be part of this. I've learned a lot listening to the great talks today. I'd like to thank everyone who's on the panel for the effort that you all put in, day out, to make our patients' experiences better. You know, they don't have any control in this situation whatsoever. You know, there are some kind of underlying common themes amongst everything that we're trying to do. Thanks, Yazan, for mentioning the Breast Advocate app, but everyone on the panel here is trying to do the same thing, and that is inform, you know, in an evidence-based way, trusted way. Thank you, Yazan. Thank you, Liz. Thank you, Terri, for contributing to the Breast Advocate app. You know, Louise, when I listened to your talk and the wonderful work you guys are doing, the one point I'd love to make is that, actually, there are 2 points. There's a big difference between e-health and health literacy, right? So one of the struggles that I had in putting the Breast Advocate app together, and this is where I learned a ton from the patients that were involved with the app, because really, I don't say that I created Breast Advocate, I say that I co-created it, because I couldn't have done it without the patients, because quite frankly, they taught me a ton. They taught me a way, rather like Liz, you know, our experience as physicians is similar there, in that we learned a lot. We learned that, well, I learned that there was a lot that I didn't know, you know, from my patients. I thought I knew how to be a good doctor, but really I didn't. And the process of creating the Breast Advocate app with that group of amazing patients really helped me become a better physician. So when I look at all the work you're doing, Louise, you know, you're looking at, you know, providing information in a way that's understandable, and that's really key. It's a big difference. You know, the health literacy is a major issue, right? We can't presume as physicians that we know exactly what Giuseppe said. We can't use complex words. We can't, but we've got to, even when you think you're dumbing it down, you're not dumbing it down enough in terms of lay language. Okay, we don't do a good enough job. The other thing that we need to help people with is navigating the healthcare system that they are in. And when you look at the differences in healthcare systems, even within different regions of the same country, right? I mean, it blows your mind how hard it is. And so when you've got a breast care nurse, a navigator on the end of the phone who can help you navigate your local system in particular, that's a massive deal. That's a massive deal. You know, a decision aid that's used by anyone in the world isn't going to be able to help you navigate the NHS in Enfield, right? Because you don't know who to call, you don't know, you know, so that work is super important, you know. So kudos to what you guys are doing. That's huge. And then I'd also like to mention, you know, Giuseppe's kind of, the way Giuseppe outlined the approach was wonderful with oncoplastic patients. But, you know, I was looking at the comments, and, you know, there was one comment about, oh, well, you know, sometimes a touch is important. You know, sometimes a touch on the patient's elbow or their forearm or something, you know, that's empathetic. You know, there's a comment about empathy. My take-home message for people listening and watching is this. What Giuseppe outlined is super helpful in terms of getting you to think about the process. But unlike everything we've been taught through medical school, this doesn't have to be a set protocol. In fact, if you look at it that way, you will probably fail. Because and this is where empathy comes in. And it's very hard when you've only got, you know, 20 minutes with a patient, right? So don't get bogged down by trying to follow a set protocol. Try to read the patient. Just try. And the fact that you're even trying and you're open to it, you will become a better physician. And also remember that shared decision-making doesn't mean you absolutely have to have 50% input each into the final decision. Some patients will just say, Doc, I'm so overwhelmed. I can't even think right now. All I know is that I want, let's say, I mean, my world is breast reconstruction, right? They may say, I know I want breast reconstruction. What would you do if I were your wife? Okay. The fact that you're giving them the option to share in the decision-making process is shared decision-making in and of itself. It's okay if they then hand it back to you and they're asking you for that direct recommendation. That's okay, because they understand they're part of that treatment planning and they want you to do that. It's not you being paternalistic and saying, okay, here's what we're going to do, without any input from the patient. Some patients are just too overwhelmed in that moment emotionally to make that decision. And all they know is that they want immediate breast reconstruction, let's say. That's all that's as much of a decision they can make. But they want you to make a recommendation. That's okay. So shared decision-making comes in a lot of ways, and I think respecting the level of autonomy that the patient is seeking is crucial in that physician-patient exchange. So I would say don't get bogged down trying to ensure it's a 50-50 split, because sometimes the patient doesn't want that, and that's okay, right? So that's just a few points to kind of.
I think as long as they understand the options and you have explained everything to them, then the decision making can be, that's part of the shared decision making. I think before we go back to the points, many points that you raised, Minas, I will ask Giuseppe a question. But before we go that, there is a pandemic happening, and we don't want to ignore the fact that there is pandemic happening, and many people were asking about COVID, vaccines, advice, for example, chemotherapy, not breast cancer patients. Is there anything that is shared, Louise, on COVID in relation to breast cancer patients on the breast cancer now website?
Yeah, so we do have pages about COVID and COVID vaccines. We did a webinar back in February, and again, we regularly update our web information. We signpost to Cancer Research UK, which has an amazing vaccine blog, which is regularly updated, and any sort of studies that are looking at cancer patients are included in that blog, and sort of guidance on and what we issue within the UK, certainly. So that's, I would say, go to our website and have a look at that information, or Cancer Research UK science blog.
So even clinicians sometimes struggle to know what to do with vaccines, especially with chemotherapy and cancer treatment. So that's very helpful, very useful. So check the website for the guidance. Giuseppe, I always enjoy your talks. You always make me think. I think I always mention that 2 talks changed many things in my practice in ABS. One was Giuseppe when we talked about the escalation of breast surgery, I think 2017, 2018. And one was Liz when you talked about your experience also was in ABS 3 years ago. So those are one of the two of the talks that I always remember in my life. Now, from the talk today, do you want to comment about evidence versus preference? Because, and the other thing we want to talk about is, like Minas said, there's always a human touch, like somebody commented about the touch might be something different, but that will be different in different backgrounds and different cultures. So let's start with the evidence versus preference. What do you want to say about that, Giuseppe?
Thank you very much for your comments. Yazan, is also a pleasure for me. So first of all, yes, I like the comments from Minas, because at the beginning of my presentation, when I've introduced the 3-talk model, if you remember, I said that this is not a linear model. It's not a step-by-step. It's kind of a circular model in which the team talk is part of the option talk and then part of the decision talk. And it is clear that sometimes patients are overwhelmed with information. And so it is also clear, and it is definitely acceptable, that some patients decide not to make a decision, provided that they receive reliable information. If they are properly informed, they are fully entitled not to make a decision and delegate the decision to the surgeon. But the point is, if they are properly informed, so this is not a paternalistic approach. Listen, I understand everything, but I'm not able to take a decision, and I rely on your point of view. I'm absolutely not able to take a decision. You can offer time. You can offer a second opinion. You can delay, but at a certain point, if she is a very well-informed patient, she can refuse to take a decision. And finally, there is the topic that was mentioned by Yazan, evidence versus preference. We discussed a lot with Professor Elwin this topic. Evidence is not the rule anytime. Patients are fully entitled to decide not to follow the evidence. Don't forget that the evidence, even if it's provided on the highest level on randomized controlled trials, is not personalized. It's based on trials, and trials are involving a very narrow population. But I'm not in the trial. So I know that this can sound kind of a revolutionary language, but a patient is entitled, obviously, provided that the physician agree with this decision, to refuse the evidence and follow her personal preference. Clearly, if I have a widespread BCIS and I want to have breast conserving surgery, well, of course, this is not possible. I cannot cure your disease. But if I want implant-based reconstruction, and I know from evidence that if I have also radiotherapy, this is going to cause morbidity compared to autologous flats, well, this is the evidence, but I can refuse the evidence and I can still go ahead with an implant-based reconstruction. It should be reasonable, of course. You cannot do breast conserving surgery in a patient with a widespread BCIS. But again, the amount and the quality of information is the starting point in the shared decision-making process, in an effective shared decision-making process. And I agree with you that empathy is not a protocol. Empathy is your ability to read in the eyes of your patients. It's an entirely human ability that we need to exercise, because we are not computers. We got very good computers that can provide diagnosis for us, but then in front of us, we have a human being and we need to act as a human being. Okay, I hope to answer to your questions and to your comments.
That's great. And I think in the setting that we work in the UK and in the States and in Europe, we're blessed to have breast care nurses. I don't think that many people appreciate how much work they take off our back, because it's that 10-15 minutes that you give the cancer diagnosis, discuss a couple of things. And I think the breast care nurses pick up lots of the pieces after we finish our consultation, unfortunately. And I think it's very important for people to appreciate how important is the presence of the breast care nurse during that consultation, not only for you as a surgeon, also for the patient. So they are the connection between both. I think they're part of the trust, or the circle of trust for the whole treatment plan. The other things about choice versus or evidence versus reference. I think there was a discussion in the ABS or between you and somebody else, Liz, about mastectomy or breast conservation surgery. For me, if it's oncologically safe, whatever the patient wants gets. So I had patients with 6mm tumors, they wanted a mastectomy. So what happens is that I give them the evidence, tell them about lumpectomy, tell them about mastectomy, tell them about the treatment plans, and tell them, I think the best option will be a breast conserving surgery, but if they want to have a mastectomy, that's their choice. It's oncologically safe. Who am I to deny them that if it's oncologically safe? Sometimes, exactly. Sometimes I give them the option of, listen, go and think about the option and come back next week because, and I always, when I finish the consultation, say, this is the plan for the surgery, tell them this is not a contract. You can just you can change your mind the time you leave the consultation room here.
I think, sorry to butt in, for many, it's the impact of radiotherapy. I live in a small village and I had almost a 3-hour round trip to have a 5-minute radiotherapy treatment every day for 3 weeks. And I've had a lot of patients angry saying, I am exhausted, I've got skin burns, I wish I'd never had it. You didn't tell me I could have had a mastectomy, in and out on 1 day treatment done. And I think as long as patients are properly consented, it's okay if they don't want us to play and do pretty operations.
That's true. And it's at the end of the day, it's the patient's cancer, we treat it together, and it's their choice what they want to have. Terri, I can see your hand raised.
Yeah, I wanted to just kind of circle back to what Giuseppe said about the evidence-based information, but also kind of tie into what Liz just said. In my instance, I had a second diagnosis, and it was advised for me to have chemotherapy again. I had it the first time. That was shocking information for me. And so I sat down with my husband, who is a mathematical genius, and I had that privilege to be able to sit down with him and look at really what the benefits of chemo were. Liz, you talked about that earlier. It's a low percentage advantage. It was for me. And the message I want to give here is for patients, if you're confused about a hard decision like this, get a second opinion. Go to another trusted source. When I did that, what my oncologist told me in this situation, she said, you've looked at what the evidence is, you've looked at what the benefits are. Because you had chemotherapy before, you are a perfect candidate to be able to make this choice now yourself, and I respect that. Now, having said that, I had to live with that decision. I had to live with that decision, and I live with it even now. So some of the changes that I made myself were my lifestyle changes. I took all those stackable items, health, the way I eat, alcohol consumption, to Liz's point, exercise, all of those stackable items that have been shown to reduce your risk of recurrence. And you make the decision and you live with it based on that science. But again, empowering patients to get a second opinion, but you've got to know the evidence, and you've got to have your patients understand that they've made their decision based on that evidence. So that's kind of why I raised my hand on that.
And before we ask, I think we'll ask Liz to wrap this up, because it's nearly 7 o'clock. We've been online for nearly 2 hours. Before we wrap this up, please remember that in 3 weeks' time, we have a chest wall perforator flap webinar. Registration is open. You'll get the links in your follow-up email. We have a webinar after that about Back to the Future, AR, AI, and VR in breast surgery. So that will be interesting, new concepts in breast surgery. Also, you get the links for that in the email after this webinar. Liz, how do you want to wrap it up?
Yeah, I've got one tip for any healthcare professional listening, and it's this. Whenever you tell someone they have breast cancer, you know what you're going to tell them. You discuss it in an NDT, you have a clear plan, you know what's going on. But that patient has never heard it before. And I've done it. You say, it's cancer, we need to do a mastectomy. You don't give them the time to think, to come to terms with it, and then ask the most important question on their mind at the moment that might transform how you treat them, such as looking after a disabled child or looking after family. And if you can just think, when you say it's cancer, and just count to 5 in your head, sit on your hands, it's really uncomfortable, but give them the time for that information to sink in, so they can then tell you what they really think before you start doing it. And thank you so much for spending 2 hours this evening listening to all of us. I've learned so much from all of you, so thank you.
That's great. Many thanks for all the speakers and the panelists. It has been great having you all again on the webinar, and thank you for giving up your time. And thank you for all the participants that joined again. It's great to see that we hit 400 again tonight. So for people in the States and South America, have a lovely day. People in Europe, have a lovely evening. And people in the subcontinent, the Middle East, have a good night. Thank you, everybody.
Bye.
Thank you.
Bye.